is now starting. All attendees are in listen-only mode.
Hello. Hello? Did we lose Leo?
Prof, you're still muted.
Sorry, can you hear me?
Yep, there you are.
We can now.
Okay, Eric, did I just continue? Eric?
Yes, I think you would just continue.
You can start with your introduction.
Okay, I'm starting now. Good evening, Leon van Rensburg, RSI Congress Director. It's my privilege to welcome you all to the next webinar in our series on head and neck, which is conducted by Dr. Richard Wiggins from the University of Utah, Salt Lake City, in a series of 10 lectures, which is graciously presented in his own free time to the RSSA. It's my pleasure tonight to introduce you to Dr. Clive Sperrin. Many of you may know him and many of you don't. So Dr. Sperrin is the immediate past president or previous president of the RSSA. He is a senior partner in Morton and Partners in Cape Town in the southern suburbs. He's been a very staunch supporter and promoter of the RSSA CME program. He is currently the chair of SASNI, the South African Society of Neuroimaging, which is a subgroup of the RSSA. And Dr. Sperrin has also obtained the European Diploma in Neuroradiology, as well as the European Diploma in Pediatric Neuroradiology. So he's eminently suited to be the chair of SASNI, and it is my privilege to welcome Clive to conduct this webinar. Welcome, Clive, and over to you.
Thank you, Richard. Well, it's my pleasure to welcome everyone here. I imagine that there are some who have attended the last three webinars, the Global Head and Neck Anatomy, Head and Neck Imaging Pearls, and Temple Bone Anatomy. Today will be Temple Bone Pathology. And the previous webinars are actually available via the website for those who've missed them. And for those for whom this is the first time, I will just briefly introduce Dr. Richard Wiggins, who is Professor of Radiology and Imaging Sciences at the University of Utah Health Sciences Center in Salt Lake City, and an adjunct professor in the departments of otolaryngology, head and neck surgery, and biomedical informatics. He has more than 50 peer-reviewed scientific papers, 11 books, 100 book chapters, and has presented more than 500 national and international lectures on neuroradiology, informatics, teaching, and education. And I think what is most important to us is that he really is a distinguished teacher. He's won the Distinguished Teaching Award from the University of Utah and Honored Educator Award, and we are privileged to have him doing this in his own time, series of 10 lectures, and really want to welcome everyone who hasn't heard him before and say thank you very much, Richard, and hand over to you.
Hi, Clive. Thank you so much. So we're going to continue our series today. Last time we talked about temporal bone pathology. So now we're going to talk about the pathology of the anatomy that we talked about last time. So I have nothing significant to disclose about temporal bone pathology, and we're going to look at some of the important anatomic landscape around the temporal bone and look at how pathology affects that anatomy that we talked about last time, and talk about some important imaging differentials, And this is an area where we have some very different anatomy and pathology around the temporal bone. So I'm going to try to discuss the spectrum of common pathologies in the same way that we talked about the anatomy. So it'll start on the outside and kind of go in, and we'll think about the different subunits of the temporal bone, the external auditory canal, mastoid process, the middle ear, the inner ear, and then finish up with the petrous apex over the next 45 minutes or so. So we'll start off with the external auditory canal. So we have some congenital pathology, but a lot of inflammatory things that can happen around the external auditory canal. The congenital, we're often talking about EAC dysplasia. And we try to say dysplasia now instead of atresia to remind ourselves that it's not an all or nothing event. There's a lot of very subtle cases of dysplasia that are often missed. So we call it EAC dysplasia now instead of atresia. It's thought to be more common in males. About a third of the time it's bilateral, and we have some idea of what the incidence is. The important thing here is that we're thinking about giving all the information we need to our referring docs so that they can treat that patient. So when they're thinking about reconstructing the ossicles or reconstructing part of the middle ear, we're trying to give them all the information they need. So I have 7 questions I try to answer in my reports, and I start on the outside and I go in. So first I look at the external auditory canal itself. Is the plug membranous or osseous or both? We look at the size of the middle ear cavity. Is it normal or small? We look at the ossicles. So we talked before about how we like to see a good ice cream cone on the axial CTs. We try to find the oval and the round windows and see if they look normal. And we think about a congenital cholesteatoma, relatively rare. But if we only have an atresia or dysplasia laterally, then we may have skin that's trapped medially to that. We look at the facial nerve course. We know that the worse the atresia or dysplasia is, the shorter the tympanic segment of the facial nerve course is. And we look at the inner ear structures, theoretically from a different login, but there is an association with EAC dysplasia and inner ear abnormality or hypoplasia. So here's a coronal graphic showing this. So again, we talk about the atresia itself. Is it osseous, membranous, or both? We look at the middle ear cavity. Is it normal or small? We look at the ossicles. We see here the ossicles are fused in this case. And in this case, we actually have an oval window atresia. And we see that the tympanic segment of the facial nerve is brought right up into the oval window itself. So we try to answer all those questions in our reports to give the otolaryngologist all the information they need to think about reconstructing the ear in those cases. So in otoscopic view, we know that the more abnormal the pinna is, the worse the EAC dysplasia is going to be. And they may not see anything on an otoscopic view. They may just see a complete atresia of the external auditory canal. And here's that case on 2 axial CTs. So we have cartilaginous and osseous atresia. We see that the middle ear cavity itself is small, and the ossicles are malformed and fused. And we look at the shortened tympanic segment of the facial nerve, as we see here nicely in this picture. Now, we also have some inflammatory processes. We may see keratosis obturans. This is a keratin plug that we see filling the external auditory canal. These patients are usually younger, usually under 40. This is often bilateral, and there's some association with chronic sinusitis in these cases. So here on otoscopic view of the external auditory canal, we just see a keratin plug that's filling the external auditory canal. And here on the axial on top in the coronal bone algorithm CT of the temporal bone, we can see that soft tissue filling the external auditory canal. So it goes right up to the tympanic membrane from the scutum or shield on top to the tympanic annulus, the inferior attachment of the tympanic membrane, and we see that on both sides. So the middle ear is normal and the osseous walls of the EAC are normal, but we have a soft tissue keratin plug filling the external auditory canal. That's a good appearance for keratosis obturans. Next, we can have cholesteatoma. So cholesteatoma, we can think about just as skin in the wrong place, and we'll go through the temporal bone and look at how cholesteatomas may appear at different locations within the external auditory canal. And here in this coronal graphic, we see a lesion of the external auditory canal, and we know that these are just composed of exfoliated keratin. It's just skin in the wrong place. These patients are usually older, usually over 40, and this is often unilateral. And we look for bony flecks that are left behind within this, and we think about scalloping usually of the inferior external auditory canal. So here in this coronal graphic, we can see a lesion that's destroying the skin of the external auditory canal. It's scalloping the osseous EAC, and we see these bony flecks that are left behind within the lesion itself. So in otoscopic view, we might see a keratin pearl within the external auditory canal on otoscopic view, or the lesion may be submucosal and leading to a hematoma. So here we see the normal tympanic membrane in place, but within the external auditory canal, we have a hematoma that's submucosal or below the skin at that level. So when we image these patients, here's a coronal CT. So here's the classic scalloping that we see of the osseous EAC, and about half of the cases have these bony flecks that are left behind. That's a classic appearance for an EAC cholesteatoma at that site. So here's another case where you have a little bit of scalloping anteriorly with some soft tissue, and we see that inferior scalloping of the external auditory canal with those bony flecks that are left behind. We can also see medial canal fibrosis as an inflammatory process in the external auditory canal. And here in this graphic, we see the fibrotic material that's laid down adjacent to the tympanic membrane with a crescent out laterally. So we look for that crescent to help differentiate a medial canal fibrosis from keratosis obturans that's just completely plugging the EAC itself. And these patients are frequently bilaterally affected. So here in this coronal graphic, we see some thickening of the skin of the osseous EAC. We see fibrotic material laid down against the tympanic membrane, and we see that crescent out laterally. And we nicely see that crescent on our CT examination. So here's a coronal CT on top and the axial on bottom, and we see a crescent out laterally with soft tissue pressed right up against the tympanic membrane, and that appearance is classic for a medial canal fibrosis. So we can think about a spectrum kind of inflammatory or infectious processes that may happen of the external auditory canal. So with the cholesteatoma, we have the scalloping, usually inferiorly. About 50% of the time, there are bony flecks that are left behind. With an aggressive inflammatory process like necrotizing external otitis, usually in an older patient is immunocompromised. We think about it as often being Pseudomonas aeruginosa, but we have an inflammatory process that may go down through the cartilaginous fissures of the EAC and down into the parotid, causing a parotiditis in that patient, or parotitis. Keratosis obturans, that's where we have an osseous plug completely filling the EAC itself. And with medial canal fibrosis, we have that crescent out laterally. So that's the spectrum of pathology of the external auditory canal that we might see at that location. Now, we also have some benign tumors as well as malignant tumors that may happen around the external auditory canal. And we can think about an exostosis or surface ear and an osteoma that may happen there. With an exostosis or surface ear, we have circumferential narrowing of the external auditory canal with bony overgrowth, but normal skin overlying it. So here we see that osseous overgrowth overlying and circumferentially compressing the external auditory canal. And on this graphic here on otoscopic view, we see that narrowing. So here's a real otoscopic view patient showing that EAC exostosis. So here we see that the osseous structures have overgrowth narrowing the EAC as a repetitive response to cold water, but the overlying skin still looks normal. And here's an example case, a CT axial on top and the coronal on bottom, and we see that osseous overgrowth of those structures on both sides. Now, if we don't have osseous overgrowth circumferentially, if there's just one focal area, we sometimes call that an osteoma. And here's a case where we see a small pedunculated overgrowth. That's maybe a submucosal mass that's blocking the external auditory canal itself. So an otoscopic view, here's a nice example of an osteoma correlating nicely with that CT where we just have a focal osseous overgrowth. And to finish up our pathology, the external auditory canal, we can also have malignant tumors here. So we can have basal cell or squame or melanoma, especially if you have a patient population with a lot of sun exposure. And we want to remember that lesions in this area, the first nodal drainage station will be to the parotid itself from the pin of the ear and the periauricular skin. So here's a nice clinical picture of a aggressive skin squamous cell carcinoma affecting the ear. And this patient on CT, coronal on top and the axial on bottom, we see that osseous destructive change with prominent soft tissue in that area consistent with an aggressive lesion of the external auditory canal. So next we have the mastoid process and the mastoid air cells as a location. And here, just like any osseous overgrowth, we're trying to think about, is this an osseous lesion? And is there osseous changes, aggressive osseous changes with permeative or destructive changes to the bones? So we try to figure out, is there any expansion of the mastoid air cells themselves at this level? And we want to remember that mastoid fluid is not the same as mastoiditis. Frequently, we just see fluid in the mastoid air cells. That is not the same as mastoiditis. Even if that fluid is enhancing, we know that we can sometimes get enhancing fluid in the mastoid air cells. That is not the same as mastoiditis. And we try to see, is there normal trabeculae of the mastoid air cells itself, and is there any soft tissue component that may tell us that this is more of an aggressive infection rather than just benign fluid. So we're trying to look for air fluid levels, and here we see in this case that just has fluid, all those trabeculae are still intact. So we know that this is not mastoiditis, this is just benign fluid. Now, if we do have an aggressive expansile lesion, we might be thinking about a cholesteatoma as one of those pathologies. So here we have a congenital cholesteatoma, just skin that's left behind, as we see here in this graphic posterior to the external auditory canal. So just like a cholesteatoma anywhere else, we're going to think about relatively low or isosignal intensity to muscle on T1 and bright on T2 without any enhancement for a cholesteatoma at that location. So in this axial graphic, we see a lesion centered in the mastoid air cells, and it's posterior to the external auditory canal. And we're going to have destruction of the mastoid trabeculae at that level. So here's a correlating case, and we see here on the axial CT a lesion that nicely correlates with that graphic where we've destroyed the trabeculae within the mastoid, and we see how it's starting to break through the bone inferiorly. And we see expansion of the lesion with narrowing of the external auditory canal, a good appearance for mastoid cholesteatoma. And if we do an MR in these cases, it's usually iso to muscle on T1, signal intensity prior to contrast, and it's kind of bright on T2. That's a good appearance for cholesteatoma. If we give this case contrast, we don't see enhancement of the lesion itself, but we might see enhancement around the outside of the lesion. This brings up the idea of a mural cholesteatoma, something that may undergo an automastoidectomy. So we see here in this case that we have a cholesteatoma posterior to the external auditory canal. We can imagine as this lesion enlarges, it may extend into the external auditory canal itself, and that's the idea of an automastoidectomy. The lesion may take care of itself, but it leaves behind a rind or a mural cholesteatoma that needs to be resected, otherwise the lesion will just reoccur. So here's a nice coronal graphic where we have a large lesion involving both the middle ear and the mastoid. And as it erodes into the external auditory canal, you can imagine that patient just having a lot of wax coming out their ear suddenly, and they may notice that the pain and pressure they previously had over their mastoid air cells has suddenly resolved. So that's an automastoidectomy for a mastoid cholesteatoma. When we image these cases, though, we may see cholesteatoma rind that's left behind, and that brings up the idea of a mural cholesteatoma. So here's a patient who I thought was post-operative, but this is actually a cholesteatoma that had destroyed the ossicles in the middle ear and extended in the mastoid air cells. And this patient had actually not had surgery. This is a mural cholesteatoma that's left behind in the surgical bed, or the automastoidectomy surgical-like bed in this case. And here's another patient who I thought had a canal wall down mastoidectomy, and this is just a rind of cholesteatoma that's left behind. So we can consider this a mural cholesteatoma in that surgical bed. So next we have the middle ear. So in the middle ear cavity, we're thinking about similar spectrum of pathologies with congenital, inflammatory, and infectious processes. But there are some important do not touch lesions that may happen in this area. We can get a cholesteatoma just like within the external auditory canal or the mastoid. We can have a patient with a conductive hearing loss with inflammatory disease, and we may divide up these cholesteatomas into congenital or acquired, and the acquired ones we sometimes describe as the pars tensa or the pars flaccida that may happen behind the tympanic membrane. So these patients are going to present with a white mass behind an intact tympanic membrane, and usually we're looking for a soft tissue mass with some kind of bony destruction or ossicular destruction to tell us that this may be a cholesteatoma rather than just inflammatory fluid. So in this coronal graphic, we nicely see a lesion that's behind an intact tympanic membrane, a good appearance for a pearly white cholesteatoma that may be destroying the ossicles within the middle ear cavity itself. Here's a nice otoscopic view where we see a very white pearly mass behind an intact tympanic membrane. And on imaging, we might see a soft tissue mass that's destroying the ossicles. That's a good appearance for a cholesteatoma. So here we see our ice cream cone, and we know that the ice cream scoop is the head of the malleus, and the cone is the short process of the incus. And here we have a soft tissue mass that is destroying part of the incus. So that's a good appearance for a cholesteatoma of the middle ear. Now, when we think about lesions and masses in the middle ear, we want to differentiate a cholesteatoma from an aberrant carotid or a dehiscent jugular bulb. With the aberrant carotid artery, we may have a horizontal segment of the carotid that extends up into the middle ear cavity, or a persistent stapedial artery that may be extending up into the middle ear, and that's often a soft tissue mass that may be crossing the cochlear promontory, and these patients often present with pulsatile tinnitus, so they show up with ringing in the ears, very different than the conductive hearing loss that we see with a cholesteatoma patient, where we're obstructing the motion of the ossicles themselves. So here's an axial graphic. We may have the horizontal segment of the carotid extending up into the middle ear, or in this case, we have a persistent stapedial artery that is extending up into that area. And we may have a persistent stapedial artery with a normal or an abnormal internal carotid that may be lateralized or aberrant in that level. And we see here in this graphic, we may have this odd vessel that's coming off and strangely going through the loop of the anterior and the posterior crura of the stapes, and may enlarge the anterior segment of the tympanic segment of the facial nerve as it goes along that course. So these patients are going to present with a very red mass behind an intact tympanic membrane, and they present with pulsatile tinnitus. So if we have a case like this axial and coronal CT where we have a soft tissue mass that's sitting here on the cochlear promontory, I want to try to differentiate and be sure that this mass does not actually connect to the carotid or the internal jugular vein at this level to help differentiate for us a possible cholesteatoma from an aberrant carotid or dehiscent jugular bulb. So I see here in this case that this lesion actually connects with the horizontal segment of the carotid. And I see here that we've lost the osseous bar that should be separating the carotid from this mass that's sitting on the cochlear promontory. So I know that this is actually an aberrant carotid. So this is a do not touch me lesion. I want to be sure I mention this to the surgeons before they go to try to biopsy this mass. And we also want to differentiate that from a dehiscent jugular bulb, another leave me alone lesion. These patients may also show up with pulsatile tinnitus, but maybe more of a venous thrum in that case. And in this case, we've lost the jugular or sigmoid plate that separates the internal jugular vein from the middle ear cavity. So here in this graphic, we see that we've lost the osseous bar between the internal jugular vein at the jugular bulb from the middle ear cavity. So here we do have a good osseous bar separating the carotid from the middle ear cavity, but we've lost the osseous bar separating the internal jugular vein from the middle ear cavity in this case. So these patients will show up with a bluish or purple mass behind an intact tympanic membrane. And here on a coronal CT and the correlating axial, we see that this soft tissue mass is going right up into the hypotympanum over the cochlear promontory. So we've lost the jugular plate or sigmoid plate, the osseous bar that should be separating the jugular bulb from the hypotympanum, the bottom of the middle ear cavity. Now, we talked about before the oval window finding in the coronal view with the duck head that we see in the normal anatomy. To find the round window, we find the basal turn of the cochlea, and we go posteriorly and laterally. There should be a dot of air right here. That's where the round window is. And here we see that this dehiscent jugular bulb is extending right up into the round window niche at that level. So that is where the round window should be, posteriorly and laterally to the basal turn of the cochlea. So here the jugular bulb is dehiscent and is extending right up into the round window niche. So we have a lot of inflammatory pathologies that may happen around the middle ear cavity itself. And we're often trying to differentiate, is there just inflammatory debris from some actual more aggressive pathology that may happen in the middle ear cavity itself? So when we're looking at our axial CT, for example, I want to try to figure out, is this just incidental fluid within the mastoid air cells? And again, that is not the same as mastoiditis, Or is this something that may be destroying the ossicles like this cholesteatoma? So here we see we're near the level of the vestibule and the lateral semicircular canal. So we should be near the level of the ice cream cone where the ossicles are in the middle ear. And here the ice cream cone is completely gone. So that's a good appearance for a cholesteatoma on this axial CT. Now, if somebody has a post-operative case where they've already had surgery on those mastoid hair cells, it's very difficult to differentiate some soft tissue density on CT that may be left behind in the surgical bed. Is this just post-operative scarring, or is this residual cholesteatoma in that surgical bed? That can be very difficult for us. And we want to try to differentiate an acquired cholesteatoma from a congenital cholesteatoma. The acquired cholesteatoma often shows up in patients who have a history of recurrent otitis media. They often have had PE tubes through their TM. And we think about this as an ingrowth of that squamous epithelium, a retraction pocket from the tympanic membrane itself. So we divide these up into a pars flaccida and a pars tensa. So the pars flaccida, or the primary type, is thought of as the most common. And here we have a retraction pocket that extends up into the lateral epitympanic recess, the space lateral to the head of the malleus and the middle ear cavity itself, between the head of the malleus and the scutum. And the pars tensa is the less common type, where we have a cholesteatoma that retracts up and may be medial to the ossicles. So the pars flaccida we think about as lateral to the ossicles, and the pars tensa we think about as showing up medial to the ossicles. So here's a coronal graphic, and if we have a retraction pocket superiorly of the pars flaccida, the flaccid part of the tympanic membrane, that'll show up in the lateral epitympanic recess, or the space between the head of the malleus and the scutum, or shield, of the superior attachment of the tympanic membrane. So that area is called the lateral epitympanic recess, sometimes mistakenly referred to as Prusak space. The area Prusak was actually discussing was between the neck of the malleus and the superior TM. So this area is technically Prusak space if you hear that discussed, but we often call this the lateral epitympanic recess. So this is a coronal graphic of a pars flaccida cholesteatoma. So the pars tensa type, if we think about a retraction pocket of the tense part inferiorly of the tympanic membrane, may retract and show up medial to the ossicles and push the ossicles out laterally. So that is going to narrow the lateral epitympanic recess, or Prusak space, and it may push the head of the malleus up against the scutum as it starts to erode the ossicles at that level. So when we're trying to image a cholesteatoma, we usually think about CT as being our study of choice. And in these cases, we think about a non-dependent homogeneous soft tissue mass in the middle ear with some kind of bony erosion. If we do see that, over 90% of the time, it's going to be a cholesteatoma, even though we may only see that in about half of the cases. And again, on MR, just like cholesteatoma anywhere else, we think about a lesion that's isointense to muscle or brain on T1 and bright on T2. So here's an otoscopic view where we see a retraction pocket of a cholesteatoma, the pars flaccid type, with this pearly white mass near the superior pars flaccid portion of the tympanic membrane. And when we do the CT, we expect to see some kind of osseous destruction. But again, on CT, we're just looking at density. So it's hard to tell, is this cholesteatoma or is this cholesteatoma filling the mastoid hair cells, or is this just fluid that's obstructed because we have a mass in the middle ear cavity itself. So we have some checkpoints that we think about as we go through for a cholesteatoma with osseous erosion. So we have our bony erosion that we may see of the ossicles. We think about the facial nerve course itself. We may have a fistula into the inner ear structures themselves. We may have a third window effect if it erodes into the lateral semicircular canals. And we may have dehiscence through the roof where we may have intracranial spread, and that may lead to a meningitis or thrombosis because we have the dural sinuses at that level, or an intracranial abscess if we have infected fluid extending intracranially. So we have a couple of checkpoints that we want to think about with an acquired cholesteatoma. Does the lesion go through the roof, the tegment tympani? Does it go into the inner ear structures? Is the facial nerve intact or separated? And we look for that sinus tympani, the important area we talked about previously in anatomy, and we try to figure out, are the ossicles there? Do we have a normal ice cream cone on that case? So here's a case where we've eroded through the roof, the tegment tympani with this cholesteatoma, and we think about the little labyrinthine and tympanic segments of the facial nerve. We try to see if that's intact at that level. We may have a fistula formation. So here we see the vestibule and where the lateral semicircular canal should be coming off. This cholesteatoma has eroded into that lateral semicircular canal. So we might have a third window effect in this case. Again, we try to find that facial nerve canal. Is there a good white line osseous bar separating the tympanic segment of the facial nerve from the cholesteatoma? And we know that sometimes the tympanic segment may already be dehiscent. We may just have the facial nerve without a good osseous bar separating it from the middle ear cavity itself. And we look at that sinus tympani. Again, here's that axial temporal bone normal anatomy CT that we talked about last time. So here's the descending or mastoid segment of the facial nerve. So the air-filled recess right next to that we call the facial nerve recess. There's a bump next to that that we think about as kind of pyramidal shape. So that's the pyramidal eminence. And we think about the little stapedius muscle coming off of there. So there's a little branch from the descending mastoid of the facial nerve. That is the stapedius nerve that supplies innervation to that stapedius muscle. And from the bottom of the pyramidal eminence over to the windows, we think about that area as the sinus tympani. That's a difficult area to evaluate on otoscopic exam. So it's our job to tell the surgeons if there is cholesteatoma at that level. And again, we try to find the ossicles. Here's another case where we're at the level of the vestibule and the lateral semicircular canal. So we should be near the level of the ice cream cone. And here the ice cream cone and the ossicles are already destroyed in this case of a cholesteatoma. And again, we look at the window. So here's another case in the axial view. We find the basal turn of the cochlea, and we look posteriorly and laterally. That's where the round window should be. And here we see cholesteatoma extending up into the round window niche, pressed right up against the round window itself. So we want to try to let our surgeons know if the cholesteatoma is extending up into the oval or the round window. Now, another infectious or inflammatory process that we might see here is trypanosclerosis. If we have a patient with long-term infectious or inflammatory changes and a long-term history of chronic otitis media, these patients will show up with a conductive hearing loss. So this is important to try to get this clinical information when we're thinking about working up these patients. If somebody tells me a conductive hearing loss patient is coming in, I'm thinking about doing a CT. I'm thinking about looking for a problem from the windows out. And when I do that CT, if it's well done, I want to keep looking until I find something that may be some thickening of the suspensory ligament or some subtle finding that may be causing that conductive hearing loss. If somebody tells me sensorineural hearing loss, I'm probably thinking about doing an MR, and I'm thinking about looking from the windows in for that problem. So with trypanosclerosis, where we have a long history of infectious or inflammatory changes in the middle ear, we have calcific debris that may be laid down in the middle ear cavity itself. So in this coronal graphic, we see that we have this calcific deposits not only on the ossicles, but also in the tympanic membrane itself. And if this goes on for long enough, we can think about ossicular bone loss with a long-term history of tympanosclerosis. So here's an otoscopic view in a tympanosclerosis case where we see a tympanic membrane perforation. And in addition to the normal ossicles, we have all these other structures that look like they're happening within the middle ear cavity itself. So here's an axial CT in the correlating coronal on bottom. And we see, in addition to the ice cream cone, we have all these other calcific deposits that are around the ossicles themselves. And here we think about where the scutum and the tympanic annulus are. We have all the soft tissue filling the tympanic membrane. We're near the oval window niche that should be near the level of the duck head and the coronal view. And we have all these calcific deposits within the tympanic membrane and within the middle ear cavity itself at that level. That's consistent with tympanosclerosis. Now, we can also have cholesterol granuloma. These may present in the petrous apex or in the middle ear cavity itself. We think about a cholesterol granuloma as being old blood products, a post-inflammatory granulation tissue that has cholesterol crystals. But the blood products help us make these diagnoses. So on CT, we see a non-enhancing middle ear mass without bony erosion when they're small, but as they expand, we can have kind of a benign pressure erosion and expansion, especially when we see it in the petrous apex. And on MR, we look for the bright T1 and T2 signal intensity that tells us that there are blood products at this level. So here's a coronal graphic where we have a cholesterol granuloma filling the middle ear cavity, and we see this outward bowing of the tympanic membrane itself. And when we do a CT, here we see a large destructive lesion of the middle ear cavity itself. And it's hard to tell if we look at this, is this a post-operative case and exactly what's going on? Because on CT, we're just looking at density. But if we do an MR, we can look at the T1 and the T2 image, and we see this very bright signal intensity on both the T1 and the T2. That tells us this is consistent with blood products. If this is before contrast, I know that's not an enhancing lesion. There's only about 6 things that are bright on T1, so I have to put in one of those categories. If I have a fat-saturated image and it stays bright, I know it's not fat like we see here in the petrous apex. Is this proteinaceous material? Is it blood? We sometimes talk about melanoma having the melanotic and amelanotic types. That may be bright on T1, as well as proteinaceous material and blood products. If it's bright on T1 and T2 and it stays bright with fat saturation, that's a good appearance for cholesterol granuloma with blood products within the middle ear cavity itself. We do have some benign tumors that can happen within the middle ear cavity itself, and we'll start off with the paraganglioma. We think about it as a benign neural crest tumors, and these paragangliomas, we give them different names based on where they occur. If it's just a small paraganglioma sitting on the cochlear promontory, we call that a glomus tympanicum. But if it's a larger paraganglioma centered in the jugular foramen, then we call that a glomus jugulare. And theoretically, if we wait long enough, these lesions can extend superiorly and laterally into the middle ear cavity itself. These patients may show up with pulsatile tinnitus and have a red vascular mass behind an intact tympanic membrane. So here's a coronal graphic where we have a small vascular lesion sitting on the cochlear promontory. That's a good appearance for a glomus tympanicum. Those will show up and present with a very red mass behind an intact tympanic membrane on otoscopic view. And here's an example of the importance of clinical information. If I have this patient and the patient shows up and only clinical information I have is something like rule out abnormality or look for pathology, this is a very small lesion sitting here on the cochlear promontory. I may completely miss this, but I called up my neuro-ontologist and he said, yes, there's a very small red mass behind an intact tympanic membrane and the patient has pulsatile tinnitus. So this is a very small glomus tympanicum in this case. And I want to be sure that I have an osseous bar separating the carotid from this mass, and I want to separate the internal jugular vein from that mass that may both present with a very red mass at that level. So here's a larger glomus tympanicum, and again, I want to see a good osseous bar separating the horizontal segment of the carotid from this mass itself. And here nicely in the coronal view, I also see a good osseous bar separating the small glomus tympanicum paraganglioma from the carotid at that level. So moving on to the inner ear, we do have some congenital and inflammatory processes that may happen here, and there's a spectrum of pathology that we think about happening with the inner ear structures themselves. One of the things we look for is just hypoplasia of the cochlea itself. So if we do the oblique views that we talked about before with normal temporal bone imaging, we think about 2.5 or 2 3/4 turns of the cochlea, and if we have hypoplasia, like we see in this case, that's a good appearance for hypoplasia of the cochlea. We also see superior semicircular canal dehiscence with thinning of the bone over the roof of the semicircular canal. So here in this coronal graphic, we see that we may have lost the bone above the superior semicircular canal. The arcuate eminence is sometimes referred to that bump over the superior semicircular canal that we see in this coronal graphic. And here's a nice correlating case with the coronal CT. We're at the level of the duck head and we find that superior semicircular canal, and we have lost the osseous bar above the roof at that level. So that's a good appearance for a superior semicircular canal dehiscence. These may be incidental, but the patient may have a unilateral beating nystagmus at that side, sometimes referred to as Tullio's phenomenon, the clinical presentation of these cases. And if we're very subtle, we may see those in other cases. This is a patient who's actually referred, and we did a mesiotemporal sclerosis workup with coronal thin T2 sections, looking at the amygdala and the dentate gyrus and the mesotemporal lobe. But when you look closely, you've actually lost the osseous bar over the superior semicircular canal. And this patient, who we thought was presenting with seizures, was actually presenting with that Tullio's phenomenon and a unilateral beating nystagmus. So here's a nice projection with the short axis or postal projection where we've lost the bone over that superior semicircular canal. This is a nice view because we sometimes see both the oval and round windows on the same cut connecting here to the vestibule. So on this side, we see a good osseous bar covering the roof of the superior semicircular canal, and here we've lost that osseous bar. These short axis or postal projections are nice because I can tell you exactly how much osseous structures we've lost at that level. We also have an enlarged interlymphatic ductor sac that we may see posteriorly. It may be unilateral or bilateral, and this is probably one of the most commonly missed causes of congenital deafness in patients. So here's a case where we're at the level of the, on this axiographic at the CP angle cistern in the internal auditory canal. We see the cochlea, the vestibule, and the semicircular canals, and we have an enlarged vestibular aqueduct and sac in the back. So technically, there's only a couple of millimeters of duct. The rest is actually endolymphatic sac. And we see that near the level of the semicircular canals. And we can use the width of the semicircular canals as an internal standard. The endolymphatic duct and sac should be thinner or the same width as the semicircular canals themselves. So here's an axial CT on top, and we see enlarged endolymphatic ducts and sacs. We sometimes call that large vestibular aqueduct on CT. And the correlating enlargement on MR, we sometimes call LESA, or large endolymphatic sac anomaly. So if you hear large vestibular aqueduct or large endolymphatic sac anomaly, those are thought of as the same entities. We just say LVA on CT and LESA on MRI sometimes to differentiate those. Labyrinthine ossificans, if we have abnormal post-inflammatory ossification within the membranous labyrinth, we think about those fluid-filled structures with the perilymph and endolymph. If we have compromisation of the membranous labyrinth where that perilymph and endolymph is, we can have increased density left behind in that area. So here's a case where instead of having fluid density in the vestibule, lateral semicircular canal, and cochlea, we see increased density on CT, and on the CSF bright sequence on MR, whether that's a KISS or a SPACE or a T2-FSE or SPACE imaging, we've lost the CSF bright signal within the vestibule and the semicircular canals. That's a good appearance for labyrinthine ossificans. So next is otosclerosis or otospongiosis. We think about these as different types. We sometimes divide it up into a fenestral or a cochlear type. The fenestral is thought of as the most common. These patients show up with a progressive conductive hearing loss, but it may be mixed, and it's frequently bilateral. So the fenestral type, we think about new plaque formation at the fissula antifenestrum, the small fissure in front of the window that may happen. So we have abnormal osseous bone there. So early, the oval window may appear too wide. That's kind of the otospongiotic phase of otosclerosis. And late, we have plugging of the window. That's when we have buildup of bone at that level. We may have laying down of spongy bone or abnormal bone. That's more of the otosclerotic phase. So here's a coronal graphic where we have abnormal bone around the oval window. So that's what we'll see with the fenestral otosclerosis or otospongiosis. And if we have a very subtle case here, you see how easy it is to miss this. If we think about the basal turn of the cochlea and where the round window should be, on the other side, that area right there is the fissula antifenestrum, the small fissure in front of the window. So this is a very subtle case of fissula antifenestrum or fenestral otosclerosis or otospongiosis that we see nicely here on the coronal CT. So this otic capsule, densest bone in the body, should be bright white all the way around those structures when we think about that anatomy. So that's fenestral otosclerosis or otospongiosis at this site. And if we lose bone all the way around the cochlea and the vestibule and the semicircular canals, then we think about that as the cochlear type of otosclerosis. Here in this graphic, we see nicely loss of the bone all the way around the cochlea and the vestibule. So here's a nice correlating case on CT where we've lost bone at that area. So there should be bright white bone all the way around the cochlea and the vestibule. Densest bone in the body, that is the otic capsule. So we think about that bone as the densest bone in the body should be bright white. We want to differentiate that all the time when we're thinking about that subtle anatomy here. And we want a very wide window to differentiate those cases. So we want a window level something like 4,400 so that we can see those subtle changes there at that level. Now, to finish up on this case and on this study, when we think about cholesteatoma and how we image it on MR, usually it's ISO to brain on T1, wherever it shows up around the temporal bone. And we think about a cholesteatoma, we have some idea of what that is on an H&E stain itself. And we know that the cholesteatoma is similar to an epidermoid cyst or epidermoid tumor that we often talk about in the CP angle cyster. Now, we're often trying to differentiate an epidermoid cyst from an arachnoid cyst. Both of these are common lesions that we may see around the CP angle cyster. And both of those are very bright on T2. It may be similar to CSF. Now, we know that we can use the FLAIR imaging because the arachnoid cyst should follow CSF signal intensity on all sequences, whereas the epidermoid cyst should not have complete attenuation on FLAIR imaging. But the diffusion imaging is very helpful to differentiate these. An arachnoid cyst is going to follow CSF signal intensity on all sequences, and it will not have restricted diffusion, but an epidermoid cyst will have restricted diffusion. So if we remember that, it can help us differentiate a cholesteatoma on our imaging. Now, if we just have a mass like this on CT, where we have destruction of the mastoid tip on this axial and coronal, we're just looking at density, so it's very hard to differentiate any kind of marrow replacing process that may happen here. This has a wide differential: METs, myeloma, lymphoma, leukemia, plasmacytoma, EG, sarcoid. This could be a lot of different pathologies. But if we pay attention to the imaging sequences on MR, this lesion was bright on T2, it's ISO to muscle or brain on T1. The lesion itself did not enhance. Sometimes there's enhancement around a cholesteatoma because we think about blood vessels being pushed to the outside and the periclastic reaction that is on the outside of the cholesteatoma. But the diffusion sequence being very bright on the diffusion and dark on ADC helps us make this differential wherever the cholesteatoma may show up within the temporal bone itself. So here's an example of a similar case. This is the petrous apex. This lesion is bright on the T2. It's ISO to brain or muscle on T1. The lesion itself does not enhance, but there might be a little bit of enhancement around the outside. But if I do a diffusion sequence, I can tell you exactly what this is. This is bright on diffusion and dark in ATC. So I know this is a great appearance for petrous apex cholesteatoma at that site. So I can use that diffusion sequence that we usually talk about using in the brain for ischemia to instead look for cholesteatoma. And whether using an EPI or a non-EPI or coronal or axial, whatever you're using to decrease the air attenuation and blooming around the air-filled mastoid air cells, we can use that diffusion imaging around the temporal bone to distinguish cholesteatoma for us. So that is a quick run-through of some of the common pathologies we see around the temporal bone and some of their differentials. And I thank you very much for your attention. So I think we have a couple of minutes for questions if anybody has any. Thank you.
Richard, thank you for taking that.
Over to Clive. You can please submit your questions on the email box and we'll answer them.
I see. Thank you for the series of talks from Shailendra. That's not a question, though.
Let's see, what are reliable imaging features of subtle otospongiosis? So we look for that very subtle loss of bone density around the physial antifenestrum and around the cochlea. Again, that should be densest bone in the body. So the reliable imaging features looking at when we're thinking about otospongiosis or otosclerosis is loss of the bone density of the otic capsule. That should be densest bone in the body around that area. So that's what we're trying to think about. Somewhat heterogeneous but normal otic capsule is something that's hard to think about, especially in pediatric cases. We often see cases that look like there is what some people refer to as a cochlear cleft around that area. So if we, let's see if I jump to this slide. Here we see a cochlear otosclerosis. So here we've lost the bone density around the otic capsule. It should be very dense bone around that area. It should be bright white all the time. That's when our imaging sequences in a window level setting are very important. If we're doing a temporal bone or skull-based CT, I want a very wide setting. So window level something like 4,400 so that I can see these osseous changes. And when I think about the fenestral type, the fistula antifenestrum, I should see bright white bone all the way around the cochlea and the vestibule. So this is a very subtle case of fenestral otosclerosis or otospongiosis, where we've lost bone focally at this location. So a practical approach to distinguish between these two entities. Some people divide up the fenestral and the cochlear types. I think about them as a spectrum. So I think a lot of these cases probably start as the fenestral otosclerosis, and then over time it develops into the cochlear otosclerosis or otospongiosis. So it's probably a spectrum of pathology. And what do I say if I can't distinguish on imaging? I just tell them to correlate it. There is technically a bluish tinge that might be seen, sometimes called the Schwarzschild sign, through an intact TM if the patient is presenting with a hearing loss that they may think about. And we're going to be more sensitive on those cases when we're thinking about otosclerosis or otospongiosis. Do you have to use non-echoplanar DWI or DTI? No. Whether you're using DWI or DTI, whatever works best on your scanner, and you can work with your vendor, whether it's an EPI version of diffusion or non-EPI version, whatever works best for your scanner and your device. For the postural and Stenberg's projection, yes, I do routinely do those on my sequences. So I acquire in the axial plane, and then I do coronal, and I do a short axis and a long axis projection for my CT. And I also get a kind of a standard algorithm like a soft tissue neck version of the temporal bone CT with a wide field of view, because you see that you really can't evaluate the soft tissues right next to the posterior fossa, the middle cranial fossa, if you're just looking at the bone algorithm, the maximum edge enhancement. The functional evaluation of eustachian tube. Boy, that's a difficult thing, Joseph. Anytime we see unilateral fluid filling the middle ear and the mastoid, the next area we want to look at is the nasopharynx. And we think about that torus tubarius and the opening of the eustachian tube immediately in front of it. So the functional evaluation of the eustachian tube is really something that the ENT surgeons do on scoping examination. So they can see the eustachian tube and they can be looking at it while the patient swallows and try to think about whether or not it's opening. So eustachian tube dysfunction is not something that I routinely think about as an imaging evaluation. Do I use regular CT or cone beam? I'm using regular CT. If you really, yeah, the cone beam is very fuzzy. I agree with you, Davison. The cone beam CT, you really have to work very hard to get the images really nice. So I'm still using routine studies, but I do sometimes see a cone beam CT that may be sent in from outside studies. Diane, asking about ceromen and keratosis obliterans. So keratosis obturans that we think about just a osseous plug filling the external auditory canal. What we usually see is just cerumen. It's just debris in the external auditory canal. So with keratosis obturans, we have a complete osseous plug that's completely filling the EAC itself at that level. So we try to differentiate that way. If it's just a little bit of debris, I'm usually thinking that's just cerumen. But with keratosis obturans, we have a complete osseous plug filling the external auditory canal with normal osseous walls. Does a radiologist have to be aware of mention or canal wall down or modified radical? There have been multiple surgeries. Yeah, it's often hard to tell if it's distorted. I think we're going to talk about postoperative temporal bone next, so that's a good lead-in. Thanks, Shalendra. But we have a canal wall down if we take down the back wall of the EAC. A canal wall up is if we leave up the back wall of the external auditory canal with the mastoid. And a radical is just taking off all of the ossicles in the middle ear without trying to reconstruct the ossicles. And if we just put a big myocutaneous bulk flap and fill the surgical bed, that's a radical mastoidectomy. So the best view or orientation for identifying semicircular canal dehiscence, if you pay attention, Johannes, on the coronal, you can see the superior semicircular canal, but that's where those short axis or postural projections are very nice to see those. So if you want to do those short axis projections, that's very nice to differentiate those cases. So in this view here, this is a short axis or postural projection. We see very nicely the roof that we should see over the superior semicircular canal. So sometimes the surgeons like this because I can tell them exactly how many millimeters we've lost bone. Or if we think about this as a clock face with noon immediately above and 3 o'clock straight out, I can tell you that we have dehiscence here from about 11 o'clock to maybe 2 o'clock on the clock dial on this view. So that's a radial information that we might give for dehiscence. So if you pay attention, either the coronal or the short axis, this postal projection from the old pneumoencephalography days is a nice view to help that orientation for loss of bone over the superior semicircular canal. Let's see, so I think that's all the questions we got here. So I think that's it. Thank you, guys.
Hello, Clive, are you there?
Hello. Yes, I'm there. Yeah, Richard, thank you very much for your 4th lecture, and we really look forward to your next one or for the next lectures as well. This lecture will be available via the website for those who need to go back on it. And yeah, thank you to everybody for attending. I'm not sure how many we ended up with in the end.
We got 104.
Okay, thank you very much, everybody. And in the words of Walt Disney, that's all, folks. Have a good night. Thank you, Richard. Thank you, Clive.
Thank you.
Thanks,
Good night, South Africa.
Good night.